Okay, welcome everybody. I see IMA's here. Hi, IMA. Good to see your name up there. Now, if anyone wants to show their video, I'm happy to see your lovely faces. I'm going to go ahead and share screen here. Just to review a little bit about the HRV biofeedback from previous seminars. The protocol I'll be describing a little bit later, but basically we're trying to get some basic HRV baseline data from everybody, and we put it into this program called Cubios and kind of get a snapshot of where their autonomic nervous system is. The biofeedback depends on finding the right frequency of slow breathing from somewhere between 7 to 4.5 breaths a minute. And then the people practice that on a regular basis. I'll kind of describe that later. Today we're talking about the gut, which consists of, as you can see, the stomach, the small and large intestines, and it's a big long tube with some chambers in the middle that basically has as its function to take fluids and nutrients out of the intake of food, and whatever's remaining as waste to come out the other end in a nice, healthy way. It's sort of a miracle that it ever works. There's a lot of stuff that has to happen. But it is a very interesting system for us because it's so much dependent on the autonomic nervous system. And there's quite a lot of history behind gut-brain interaction. Some of the pioneers of modern physiology, like Walter Cannon, considered the father of modern physiology, wrote a book in 1936 called Digestion and Health, in which he outlines all of the brain-gut connections. And many of his colleagues and students, Wolf and Alvarez, I have written extensively about what they realized was a very important connection between that. It is also recognized by Darwin early on that the gut had a very strong connection to brain-gut connection. And even as early as 1921, there was some attempt at physiological measurement, non-invasive measurement of the gut with an electrogastrogram, EGG. And currently we're working with a modern AI version of EGG called telemetry, which gives a remarkably good picture of what's going on in motility in the gut. In almost all species, the digestive system is kind of the core of the beginning of the evolution, and things kind of go from there. So in more detail, the functions of the gut start in the oral cavity with salivary glands, with the mechanical aspect of chewing food, getting into the right thing. The pharynx propels materials down into the esophagus. The esophagus works with a kind of like a muscular tube, transports things down into the stomach. In the stomach, chemicals break down the materials via acid and enzymes, mechanical processing through muscular contractions. In the meantime, the liver secretes bile and the lipid digestion, and the gallbladder does the same. And from the stomach, and also the pancreas is playing a role by secreting digestive enzymes that are necessary for the breakdown. Then basically the food gets dumped from the stomach into the small intestine. It goes through a very long series of loops, about 10 yards long, and finally to the large intestine, where it kind of goes up and across and down, and finally is expelled as stool. The whole process really pretty much from the esophagus on is controlled by the autonomic nervous system, but it has its own internal nervous system as well. So the gut has a mind of its own, but it's heavily influenced by central processes through the autonomic nervous system, especially the vagus nerve. The brain communicates to the viscera, including the gastrointestinal tract, through multiple parallel pathways, including the two branches of the autonomic nervous system, hypothalamic pituitary adrenal axis and the sympathoadrenal axis, modulating the gut associated with lymphoid tissue, and descending monominergic pathways, modulating the gain of spinal reflexes and dorsal horn excitability. This is a quote from Emmer and Meyer, who's kind of the leading gastroenterologist at UCLA, who's kind of really brought back the brain into the gut in the field of gastroenterology, and is really very powerfully illustrated the interaction between the two. And if you're interested in more detail in that, just look up Emery Meyer. You'll find very good materials for him. The two key subcortical structures that generate these outputs are the hypothalamus and amygdala. They receive inputs from the network of cortical regions like the medial frontal cortex, including the subregions and the anterior cingulate. So the pathways are fairly elaborate. However, they're really dominated by the vagus nerve, the 10th cranial nerve of the parasympathetic nervous system. The sympathetic system plays a minor role in that when you have a major threat, it pretty much shuts the gut down from one end to the other, and plays some role in regulation beyond that, but not near as important. Once the major threats are diminished, then the parasympathetic sort of plays a role as a guiding light for the enteric nervous system, the nervous system inherent in the gut with 10 to the 9th neurons. Here you can see it's a very complex system with many different branches of these nerves that all play a role. And just show you this to give you the idea of the complexity. Here you can see in the final parts of that, the vagal fibers, the parasympathetic motor, secretory, and afferent fibers accompanying superior mesenteric artery and its branches usually as far as the left colic splenic flexure. Notice that there's many afferent fibers here as well as efferent fibers going from the gut to the brain, as well as from the brain to the gut. And this is an emerging area of great interest. For instance, all of the communication between the microbiome and the brain come from vagal afferent fibers going up this pathway. Those are the ones that you see here in the blue. In a more simple way, you can kind of look at the gut as a series of layers. There's an outer shell called the serosa, which is just sort of the structure around the gut. And then there's a layer of a muscle called the longitudinal muscle. That's a muscle that moves up from one end to the other, sort of moves along the axis of the gut. Between there is a very elaborate nerve plexus called the myenteric plexus. That's one that has 10 to the 9th neurons. And then it also controls then the circular muscle, which is a muscle that coordinates just by squeezing, but not moving along the axis of the gut. And then there's a mucosal layer, a submucosal layer, and then a mucosal layer, which is kind of a slimy layer to help things slide through properly. And things can go wrong in every level of this layer. But for our purposes, for the mind-gut, we really are more interested in how the brain communicates to this myenteric plexus. Here you can see a little better view of it with elaborate fibers all over the place with to ganglia and tertiary branches from the myenteric plexus, very sometimes called the third brain. There's a long road for this to happen from the esophagus, the gastric to the colonic motility. There's a lot of interest in gastroenterology or things that can go wrong at each level along the way, but from our purposes, we're more interested in how the parasympathetic system guides the enteric nervous system in this process. And you can see how that looks. An important thing for us is that peristalsis, that is the movement along the gut, is the combination of the longitudinal and circular muscles. And if you've ever seen a kind of boa constrictor swallowing a rat, you can kind of see how things are moved along through the gut until they're broken down into the way they should be. However, it is worth noting that the main sensory component of this back to the brain comes from the stretch of the gut. So when the gut is stretched, there are nerves, afferent nerves, that signal back to the brain. And really, it's the main source of pain in the gut come from those afferent nerves, especially from stretch. And here's a Emery and Meyer review that, if you're really interested in detail, I would definitely look that up. It's a very, very elaborate, detailed review. there was a popular book by gastroenterologist Gershon called The Second Brain, which he kind of goes through in layman's language really how important the enteric nervous system is, the enteric plexus, and the enteric system in regulating the gut, and how it's regulated in turn by the autonomic nervous system. 95% of the body's serotonin is found in the gut, only 5% of the brain. You may remember that the reuptake inhibitors like Prozac were discovered basically as a side effect of antiemetic drugs for throwing up, that also seem to have some effect on depression in the brain. So it's really important. The serotonin is the neurotransmitter by which the information is regulated within the enteric plexus, guided by the autonomic nervous system. And so it's been long known that stress plays an important role in how the gut works. We probably all can feel this just in our own lives. And basically, the fight-flight response slows everything down, although it's sometimes very difficult to predict whether it's going to end up with diarrhea or constipation for anybody. But those are common issues from stress that we all kind of know about. And we've seen a lot of studies have shown that high-level sympathetic activation pretty much shuts down the gut. You can see the power of the regulation in terms of what we're going to be talking about by looking at one part of the gastrointestinal system, the esophagus. And this is a group in England that was interested in GERD, gastroesophageal reflux disease, which is very common, and is caused by a malfunction of this sphincter. There's two sphincters in the gut. And when these sphincters are not adequately closed, the acidity in the stomach can bubble up into the esophagus and causing burning pain and heartburn, reflux kind of pain. So we know, and then we know that both the esophagus as well as the sphincter are regulated pretty much by the parasympathetic nervous system. And so there's a whole series of events that occur here that can lead to the kinds of problems. Now, the reason that's kind of interesting is because, so just as background, the gastroenterologist, most typical tests we would care about would be an upper endoscopy or a colonoscopy or a lower one, where they put tubes in to be able to see what's going on. In my age, I've had a number of these colonoscopies, and believe me, it's not fun. But just so you're aware that those are the kind of typical. Also, there's a lot of tests that use CT scans, X-rays, and other things for the gastroenterologist. Well, this group in London had kind of looked at GERD from a point of view of the autonomic nervous system, and I've given the references. It's very interesting work. And what they've done is they created a nasal gastric tube that medical students would have put down through their nasal passage down into the esophagus. The tube was able to dump either acid or saline into the gut, but it also had a series of little heated probes on the upper end in the esophagus. And those could be heated up to the point where the person could just feel a little bit of pain. And using that, you're able to actually determine an esophageal threshold for pain. And it turns out that all of it, it's a pretty stable threshold. If you have it at a certain level today, you'll probably have it again tomorrow. However, the threshold is drastically affected by acidity in the stomach. So for instance, when they dump a bunch of acid into the stomach through this tube, the threshold goes down by a ton. And so that the person feels pain much more quickly than they would otherwise. So here's the results of some studies of that. Here you can see saline, actually, the pain threshold went up a little bit when there was saline in the gut. So that means they felt less pain from the probes. But when there's acid in the gut, you can see it goes down over several hours and lowers the threshold. That means that the esophagus is much more sensitive to pain than it was before. So pain tolerance reduces with acid. However, we know that there's a relationship in the vagal tone, in parasympathetic tone, as well to the pain thresholds. So the greater the vagal tone, the higher the pain threshold in a couple of studies. And there's a pretty decent correlation between that. So we know that pain threshold is being regulated by the vagus. So withdrawal of vagal tone, as occurs in stress, will increase esophageal pain. And this group said, well, I wonder what effect intentional increase of vagal tone will have on esophageal pain. And I was doing a workshop in London when I discovered this work, which builds on the work that we've done in HRV biofeedback, which was thrilling, actually. So what they did is they trained their medical students to use the slow breathing technique that we'll talk about later, that we call heart rate variability biofeedback. They trained pretty much everyone around 6 breaths a minute, but that was pretty close to resonance frequency. And what we know from that is that we were able to change parasympathetic tone, increase the flexibility in the autonomic nervous system, and increase vagal tone with that technique. So when they did that, this is the usual one that we would use, they were able to see that, in fact, during slow breathing, vagal tone went up. This is a kind of a cool little device they had called a neuroscope, but it's pretty similar to the respiratory sinus arrhythmia that we have. But during sham breathing techniques, in other words, just breathing the way they're at their normal rate, there was no change in vagal tone at all. And then back over, it goes up when they breathe slowly. So we know we're actually able to increase the vagal tone with the breathing technique. It's been shown in many ways. And so here's what they found. They found that when they dumped acid in the stomach, they got this giant reduction in the pain threshold, much more sensitive to pain. However, when the person was doing 6 per minute breathing, it overcame the reduction in pain threshold for those subjects. The same amount of heating in the element no longer was pretty much the same as it was without the acid. So the training has a really powerful effect on the esophagus, and it gives us an idea of how it works with our patients with other disorders that we're talking about. Looking at the chat, sorry. Brain pain, do you mean headaches and such? No, that was just pain in the gut. We're talking about pain in the gut related to the brain. So you'll see how that goes in a minute. That was Sarah who's asking that. So the disorders that we're interested in are now called DGBI, disorders of gut-brain interaction. This is the gastroenterologists change the name every few years. These used to be called functional gut disorders or psychosomatic disorders or a whole bunch of other names. This is now, and it's actually not a bad name for it because these are, in fact, disorders of gut-brain interaction. So these are the ones we're interested in treating with biofeedback, so that's why we're doing that here. Wait. So these are highly prevalent disorders, 10 to 20% of the population. They constitute the primary reason people go to a gastroenterologist in pediatric and in adult care. They do not respond well to gut-targeted drug therapies. There's hardly any good evidence that any drug really works well for them. They encompass the problems regarding digestion, defecation, abdominal pain, vomiting, and nausea, swallowing, without identifiable structural pathology. So the person who has these problems goes to the gastroenterologist. They get usually an endoscopy, and then maybe a lower GI tract X-ray, and they can't find anything wrong. So then it is now labeled as a gut-brain interaction disorder. The most common one is irritable bowel syndrome, or functional dyspepsia is another one. There's another version called an abdominal migraine. Uh, these are there's a committee that meets in Rome every few years. The last time was late in 2017. So this is Rome 4. And I put in, just for your use, I don't want to spend a lot of time on it, what the consensus diagnosing criteria for a number of these DGBIs. Irritable bowel is probably the most common one. Sometimes it's called something different in kids. But usually what's bringing people into our clinics is going to be gut pain, abdominal pain. That's most commonly what will bring them into the clinic to see us. Then here's the diagnostic criteria. There's a constipation type, a diarrhea type, a mixed type, an unclassified type. You will find people have quite varied symptoms with this, but they usually fall roughly into one of these classifications. Also, just functional chest pain can be another one of these disorders. It could be esophageal pain. It could be some other source of pain, but not related to actual cardiac disease. Heartburn can be this kind of pain unrelated to actually erosion of the gut, but it can also be related to erosion of the gut. Reflex problems can happen in both in a number of different ways. And here we have functional dysphagia. So if you have referral sources in this community, that you can get referrals from swallowing therapists, from gastroenterologists, from a whole series of people that have to deal with these kinds of problems, and dyspepsia and others. We see an awful lot of kids with vomiting. It's not always cyclic vomiting, but just with a lot of vomiting and nausea. And this is now being seen as part of the Rome 4 criteria. If you're seeing kids, more recently, you'll see rumination syndrome, where the kids are throwing up into their mouth 20, 30, 40 times a day after eating anything. It's not like a full vomiting. It's a kind of a spit up into the mouth. And it's definitely related to the breathing muscles and to the autonomic nervous system. We have really good success in treating that. I see another chat. Let me see. Just saying, okay, thank you. Functional constipation, we're kind of familiar with. So you'll get some of these clients come in with really difficulty time with the stool, and then you'll get bloating and distension as another symptom that can be quite disturbing. Centrally mediated disorders of pain. Sometimes you'll get abdominal pain that seems to be related to fibromyalgia or some sort of a central pain. And then here are the criteria for those. You'll have them now, so I'm not going to spend a lot of time on these. Our clinic, we have about 40 kids on the wait list to see these functional disorders of kids. That if you approach your pediatric gastroenterologist, they are overwhelmed with these problems, and they really have no good treatment for them. So there's a giant opportunity for biofeedback to be very successful. And there's one group of physicians that understand this. It's pediatric gastroenterologists. They totally get it. So I've just put all these in here for you guys to see. And you can see they comprise a heterogeneous group of disorders, especially with pain. It's good to think of these as software problems on hardware problems, that somehow the brain regulation is what's the problem here, not the actual mechanics of the gut usually. And so you get these very complex pictures from this pain that can be labeled by any different medical people as aberrant gut brain, visceral hyperalgesia, abdominal pain, all these kind of labels mixed together and show up in a lot of the pediatric gastroenterology. And so we know that this is a very complex disorder that encompasses many things. Most of us are most interested in the emotions and coping, depression, anxiety, but sleep plays a role, trauma plays a role, peer relationships really play an important role in all of these disorders. And so it makes a very complex picture to look at. The microbiome probably plays a role, except it's so complex that we have no idea how it really works and no idea what to do about it. There are genetic components to this, and people with early adverse events are much more at risk for these problems than other people. So even though it's a multi-system disorder, pain is sort of central to the disorder. The most common adult one would be irritable bowel syndrome. Very common, very expensive, way more females than males. However, that's probably not true in the population, only in the clinic surveys, because men don't go to doctors. So we have men just grin and bear it, and women go to doctors. So we think that maybe there's a little bit more like a 2-to-1 in the population, really. And then in clinical surveys, and it's 4-to-1. Very high utilization of medical services, so that all of your health services are quite interested in dealing with these people. They're interested in you helping them cut down the amount. People come to you because they've had all normal tests. The motility patterns look fairly similar. If they have diarrhea, then they have faster transit times through the gut. Things move through too quickly, or constipation too slowly. But that doesn't seem to be related to any structural problem of the gastrointestinal system. These folks do have an increased motility response in response to an environmental or enteric stimuli. So when you stress them, psychologically stress them, and measure what's going on in the gut, they do have an exaggerated physiological response, but it's not a structural problem. The exaggerated response to intestinal distension. So the most important take-home from this is that their pain seems to be coming from an exaggerated response to distension of the gut. Remember the slide we saw before on distension? I think I have another one coming up. So that means that the same thing that you and I might feel when we have a little bit of bubble of gas and feel as mild discomfort, patients with this problem feel really excruciating pain from that. And it isn't that they're wusses, it isn't that they're responding more pain than other people. There's something going on in that like an amplifier of that pain response from the gut. And this is called visceral hypersensitivity. And we have really good evidence for this because there's been a number of studies where we put a balloon into the GI tract somewhere and blow it up slowly without the person knowing. And people with these disorders, the DGBIs, have a way exaggerated pain response, even before they know it's coming. Whereas people even with a disorder like Crohn's disease don't have as exaggerated a response, even though they have some of the same symptoms. So this is what's called visceral hypersensitivity. It's important you get across to your patient that their pain is real, quote unquote, because they think they got sent to you because somebody thinks it's all in their head and that they're really not experiencing any pain, but they're just overreacting to pain. Well, we know that's not true, and it's really important to get that point across to your patients. The sensitivity of the receptors in the viscous, it's altered through the recruitment of silent nociceptors that are pain receptors, that is, in response to ischemia, distension of the contents. There may be increased excitability of the neurons of the dorsal horn. That's where the pain messages go up. Spinal cord and area rich in neurotransmitters such as catecholamines and serotonin. Certainly, there may be differences in the way the brain modulates the efferent signals from the dorsal horn. These are the current concepts of what's going on for these patients. This was a meta-analysis of 18 studies comparing brain responses to rectal distension. That's where they put blow it up in IBS patients and healthy controls. Then the IBS patients showed greater activations of brain regions that are involved in the processing of visceral afferent information and emotional arousal and cortical modulation. So when we look at their brains and fMRIs, the parts of their brains that are lighting up that really show true pain and true emotional upset much more than they are in normals. And this is based on 18 studies, so I think it's several hundred patients now that we can see from this meta-analysis there. Here you can see, again, a picture of the lower intestine and the rectum. And just to point out that we don't exactly understand how those pain messages are sent from the lower intestine to the brain, but we do know that stretch seems to play a really important role. There's sensory fibers and afferent pain fibers that were clearly present, and they're present in everybody. They seem to be hypersensitized in our population. So an irritable bowel, the same amount of distension will produce much more pain than it would be for someone without irritable bowel. It's what I had just been saying previous. So it's important to remember in our area that although there's a lot of these patients that have comorbid psychiatric disorder, in the general population, 70% of patients with these disorders do not have any noted psychopathology. So even though there's more psychopathology in the group, in a regular population, this is a disorder that's clearly not just a psychiatric disorder. It is a brain-gut disorder, brain-gut interaction disorder that affects a lot of people without any diagnosis of depression, anxiety, or any other psychopathology. And that's important because these patients feel very stigmatized, and it's important to kind of get across to them that you're not seeing them as a mental patient. What do we know about autonomic dysregulation in these folks? Well, lots of evidence that these folks do not have a very flexible autonomic nervous system. So using heart rate variability measures, we can kind of get that. Here's a meta-analysis. We've seen lots of evidence of vagal dysfunction, sympathetic dysfunction. This is a study we did where we looked at recovery from worrying in patients with IBS and controls. Here you can see the IBS patients don't recover near as well as the controls in any of the measures that we typically use for that. Clear-cut evidence of autonomic dysregulation for these disorders. A mediational model that includes autonomic mediation can guide treatment. So the treatment model that we've designed, that we've published a bunch of stuff on and we use in our clinic, is I call a mediational models of DGBIs. We start with the disorder itself. Abdominal pain is the most common, but it could be constipation, diarrhea, bloating, or nausea. With the kids, it's very often nausea. We're assuming that is really coming from a dysfunction of the autonomic system, mostly probably parasympathetic withdrawal rather than sympathetic activation, and possibly some microbiome effects that we don't understand very well. We do know that there is some central sensitization. I mean, the brain itself is over-responding to the same signal, but that is not the whole story. There's something going on here that mediates that pain. The patients are characterized almost universally as internalizers. So even if they don't have a real anxiety disorder, they tend to be worriers, they tend to be anxious, they tend to be perfectionistic. And that seems to be what's driving this autonomic dysfunction, along with this feedback loop of having a lot of GI symptoms that cannot be diagnosed structurally. So that makes you worry even more that somebody is missing. So some of these folks go for GI, 10, 12, 13 GI exams because they are so convinced they must have some disease and they don't want to hear that it's not that. I see a question here. Sally says, vagal tone, is there a direct way to measure this? Yes, I'm coming to that in a second. It's inferred through HRV metrics, correct. So we see it through the HRV metrics. And I'll talk about that in just a second. Good question. Social cultural factors play a role. So it's really important to be a sensitive, multiculturally sensitive person. We don't think hysteria, like the early idea of hysteria, plays much of a role in these disorders. These are not really conversion disorders. So since medications don't work, let's look at the treatment. And I'll come back to the metrics that seem to work really well for that too. This is a study that compared multidisciplinary versus treatment as usual for these patients and found a big effect of using much better when you use multidisciplinary, which means including the kind of stuff we do, as well as a whole bunch of dietary things and things like that. So the best way to approach these disorders is from a multidisciplinary perspective. Medically, it's not a great way to approach it just with meds. Meds don't work. Here you can see the powerful, this was how many of the patients had a 50% reduction in their IBS symptoms. This was the multidisciplinary had like 65% did and only 35% if their treatment as usual. Even stronger for dyspepsia symptoms, and this is quality of life, which wasn't quite as affected, but wasn't very high to start with. So what's the training procedure? This is our usual HRV training procedure. Let me go back for Sally's question and say, as I said at the beginning, I didn't include that in this slide because we did in the other webinars, but what we do is we get 5 minutes of baseline HRV data. To do that, you need some sort of device that measures the interbeat interval. And it can be PPG. It's better if it's an ECG. And then there's, as I said in the very first slide, there's a program that you can get free called Kubios. Go back to the very beginning, and I wasn't planning on reviewing that, but now that I say that, I think I should. So from the 5 minutes of resting data, you export the data from whatever device you're using. And if you would want to put in your chat what devices you're using, I would love to be more specific. Thought Tech, Nexus, HeartMath. Somebody tell me in the chat what you're using. HeartMath. Okay, so for HeartMath works fine. In HeartMath, what you do is you don't use their software analysis. You export the data, making sure there's no headers or identification, into this program called Kubios HRV. So Google Kubios HRV. You can get the Kubios Lite is free. You put the IBI data, which is just the interbeat interval data that's exported from your HeartMath or from your Nexus or from your Keto or from your Infinity, into that, and then you get a really beautiful output. You're able to clean up bad beat data. There's a wonderful tutorials on how to use Kubios available in their help menu. And here are the indices that Sally was asking about. The best one is RMSSD, root mean square of successive differences. You want to get an index for 5 minutes resting. They have to be breathing normally during this time, not slow breathing. And that gives you an index pretty much of how well their autonomic nervous system, how flexible it is. So we do that before and after treatment. And now I'll go back to where I was with treatment, but let me see if I'm answering your questions okay. Yeah, so if you're using Thought Tech Infinity, the same thing. Export that data. There's a really nice export function in it. So you would export the IBI data file to Kubios, and maybe we have some time. I'll put up a Kubios slide for you, and you can see what it gives you, a really very complete, thorough picture of what's going on in the autonomic nervous system. So once we get that, now we have a snapshot of how well their ANS is working. So now we want to think about some treatment protocols, which are kind of the same ones we've used for other things. So this is the kind of standard instructions. So what we're doing is we're taking people through a series of paced breathing to determine what is the best slow breathing pace. We also teach them diaphragmatic breathing. So make sure you get them breathing diaphragmatically. And then you go through and pace them at 7, 6.5, 6, 5.5, 5. And one of those paces is going to produce the biggest respiratory sinus arrhythmia, the biggest peak valley differences in their heart rate. You can look at that as the low frequency peak, or just looking at their actual heart rate going up and down, trying to see which one produces what looks like the best, the best pace for that person. We call that resonance frequency or resonant frequency, either one. And once you've found that, it's pretty much fixed for life in adults. So now that person has to be practicing at that frequency on a regular basis. So you can use any one of these kind of pacers. You can use your HeartMath feedback to do it. You can use this keto sensor is really cheap. It's the PPG sensor is like $29. They now have a chest strap for about $19. And you put that together with the Elite HRV app. So it's really no equipment. This used to be very expensive. It doesn't anymore. You can use any one of a number of devices to try and help you figure out what that breathing pace should be for that person. And then they have to practice that on a regular basis, right? So beginning of each session, make sure we get the right pace. Once a good resonance frequency is found, they will be challenged. Then we often do is challenge them with stressors and have them go back into their slow breathing pace to recover quickly. Call this rescue breathing. And they have to get really good at that, because what we're trying to do is get them to recover from vagal withdrawal in their life, because we know that prolonged vagal withdrawal produces gut issues for everybody, but especially for these patients. So in general, with 5 or 6 sessions, we see really good results starting to emerge right away from this biofeedback training procedure, especially for some of the subtypes of the GI disorders. And this is what an old J&J pattern of thing would look like. That's just showing kind of very complex heart rate, beat by beat heart rate patterns. But then the person is instructed to start following a pacer, and slowly but surely they start moving into these big peaks and valleys. So what you're looking for is the biggest distance between the valley and the peak of these waves during slow breathing. That shows up somewhere around 0.1 hertz in the spectrals, which I think all of the devices you have. And once you get that pace and lock it in, then that's what they're practicing in. 10 minutes a day at the minimum, 20 minutes is better. We see these beautiful peaks starting to occur there. Let me go back and make sure. So other treatments that have empirical basis are hypnosis, guided imagery. There's some evidence that family interventions for recurrent abdominal pain work, but I think what really works best is applied psychophysiology. Dietary interventions don't work very well. This is a Cochrane review showing that looking at a lot of different diets, all of these patients have tried lactose restriction, wheat restriction, who knows what, probiotics, antibiotics, and none of them really worked very well in controlled trials. So the idea is to really focus on biological components first, because the person coming in with a very big fear of stigmatization, convince the patients the problem is neither purely biological nor psychological, but psychophysiological. And that's why that DGBI is a good diagnosis. The disorders of gut-brain interaction is a good description of that. Follow the mediational model by focusing on symptoms, physiology. Don't go to talk therapy until you've conquered these two things first. If you go to CBT or ACT or psychodynamic therapy when you first come into the office, that tells the patients you think it's all in their head. And that's exactly the wrong message we want to give them. So if you start by really focusing on the physiology, ultimately they'll be able to see that their cognition and emotional states affect their physiology, and that affects their symptoms. And then they're way more open to psychological interventions than they would be otherwise, especially in populations that are really very skeptical about talk therapy. So a lot of ethnic populations are, and a lot of engineers are, and a lot of computer scientists. So that's the cognitive therapy piece. Combining HRV biofeedback with protocols. This is what we do. Eventually, we move to acceptance commitment therapy. But we can see here a lot of reviews have found this to be very promising. Here's some studies we've done, just a few. In this study, we combined slow breathing with some biofeedback on hand temperature for kids with abdominal pain. We had one group that got fiber, more fiber. That's the blue group here. The orange group got fiber plus the biofeedback, slow breathing and temperature. Third group got some CBT added into that. And the fourth group got CBT and family. So they got everything. You can see the best results, which were dramatically good, were just the two couple. So they got fiber and they got the biofeedback. And basically that's the child's rating of their pain. Almost none of the kids had any pain. And there's the parent rating of the pain. And the parents said none of them had any pain in that particular group. Really strong. That was published many years ago, actually. In this study, we actually measured kids' vagal tone during a day of school and then measured that again after treatment. And so they were given a device that they wore that measured the vagal tone during a normal day. These are tricky devices to use. You wouldn't have access, but this shows you how it works. We found that the kids with recurrent abdominal pain basically had much more vagal withdrawal than the kids without it. So that means that those patterns that you were seeing up above here, we looked at those kids' pattern and measured it. They look much more like this than they did like this. So we could see that the kids throughout a day of school were going into kind of mildly stressful episodes in which their parasympathetic nervous system wasn't really regulating very well. And that's the device that they wore pre and post. And we compared them to a healthy control group just for that day of measurement. And then we treated them with the protocol that I just described to you. And it was Eric's, who was the author of this study. And you could see that the kids mastered this pretty well. Here you can see really good peak valley differences during the biofeedback training and a great peak. During that time, their hand temperature goes up, their skin conductance goes down. We really try to get them to do homework at least 10 minutes a day and keep a log of their symptoms and their practice. With one of these home devices, you can now actually have them email you the data, and you can see how well they're practicing. So we're doing that a lot with that keto device now because we can afford to get every patient to have a $19 device. It's pretty affordable. And then they practice a few days a week and they send us that data. We can see if their peaks look like this or whether their peaks are all over the place. And we know how well they're practicing that, and we can give them some feedback on that. So in this case, what we saw was that the kids had what we think of as vagal withdrawal here. Here's a kind of normal our respiratory sinus arrhythmia, and this patient got stressed here, and you can see what happens to their heart rate gets flatter and higher. That's vagal withdrawal right in front of you. So in this particular study, the kids had a great reduction in pain, as in the other studies. They also improved their vagal tone, but most important, there was a pretty strong relationship between their pain reduction and the degree to which they improved their heart rate variability. And this was a study that won an award at a gastroenterology meeting because it's a mechanism study. It shows you how, in fact, the treatment works. And knowing that there is really some good evidence that what we're doing is affecting a mechanism of pain really, really goes over well with the gastroenterologist. So, and you'll see there's a number of other studies that I've included here where you're getting really good responses from the same kind of treatment. One study with adults in Scotland used hypnosis compared to HRV. hypnotherapy has been seen to be pretty effective for IBS, but here you can see heart rate variability did a little bit better than that in that study. This was a case series that we did in our clinic. We just took 37 consecutive patients with various GI disorders, and what we did was we treated them with our usual protocol, and basically about 65% of them were completely symptom-free. About 32% were greatly reduced, and a few percent were basically not changed very much. And they varied by different kinds of diagnoses. Some were better than others, but you can kind of see that. See a chat question. If you get a chance to look at these letters from our kids, they're just lovely letters about how cute these kids are when they get better. And they breathe with their stomach, and this is to one of our interns, Megan, magnificent Megan. I never would want to be happier than I am now. And I included quite a few of these cute little letters. I'll see if I can find the slide real quick to show you what the cubios looks like. So there's kind of a picture of the cubios. It shows you the full range of the heart rate changes. It gives you a chance to correct any bad beats. And then it goes on to give you all the information about time domain and frequency domain measures that you might ever want, and some that you probably don't want. It gives you the spectral and a real good opportunity and you can just print out a PDF of that. It gives you all the information that you see there on one sheet of paper. So I would highly recommend that everybody do that. I got some chat questions. Good. I've used Interbalance, Elite HRV with the Cubios device. Do you have any opinion on optimal HRV? Yes, I think optimal is great. It is a monthly registration and fee, but Ina and Matthew are very knowledgeable. It's a very good program. It's a little tough. We'd find it's a little tough to get our patients to sign up for something where they have to pay every month, but this one is worth it. If you can get them to do it, it's really a good one. The last study mentioned the presence of some patients with inflammatory comorbidities. So for inflammatory bowel disease, Crohn's and ulcerative colitis, it's not very clear that those are really stress-related disorders, but there's a little bit of evidence that you can prevent future flares. So it may be useful for them. And many of them with inflammatory conditions do also have IBS. And so the treatment protocol works really well for the IBS component of it. You should be careful not to infer that their Crohn's or ulcerative colitis is somehow related to stress. The evidence for that is not very good. So, and the gastroenterologists hate when we do that. So you want to be really careful about kind of staying in your lane about that. But if the person comes in with abdominal pain, there's a good chance that pain might not be the Crohn's or ulcerative colitis. It might be actually an IBS component to that. Well, good. That's a really good idea. For trauma, there's a whole other presentation on trauma on this that I think we're starting to see some data we're producing and others that combining the HRV biofeedback with any kind of exposure therapy for trauma, EMDR, prolonged exposure, CPT, whatever way you do that we can get a 25% boost in response by including HRV-B, not during the exposure. You want them to really be aroused during the exposure, but before and after, and especially just practicing every day. The other thing it does is it gives these patients a wonderful safety net if you're doing exposure therapy, that they always know that you'll be able to kind of get them back down to baseline pretty quickly with this slow breathing. And it really prevents dropouts because, as I'm sure you know, Rebecca, these folks really don't want to do exposure to their trauma. And so we have covered this. My internet dropped out. How long do you tell the clients they need to practice? We tell them 10 to 20 minutes, and the 10 is the minimum. And we have some evidence from a study we just completed in Taiwan, one of IMA's former students actually, where we got amazingly good results with mild traumatic brain injury. And those folks were, and it probably has to do with Taiwanese culture, they were practicing 20 minutes a day, very religious. And every single person in the experimental group got better, and nobody really got better in the control group. And that's another presentation. But so if you can get your person to really religiously practice, how many days a week? We tell them every day, but we hope that they do it more days than not. Sorry. Yeah, for the Helicobacter pylori, probably if they've got an antibiotic that worked, then we kind of combine it with HRV. We haven't seen much data on that. I don't know, whether that would work or not. Maybe you can be the one to tell us if it works or not. We haven't really seen much of that. If they have that virus or bacteria, they've usually been treated before they come to us, so we assume that that's under control. But it's a great question. We just don't know. So we tell them every day, Sally, but who knows if they really do it every day. We try to get them to do as much as they can. Okay, I think we're about out of time. Any last minute questions?
I actually had a question. So I recently saw Santiago Brand's webinar on neuroinflammation, and he does talk about the gut a lot and how how your diet can also change the inflammation in your brain. Is neuroinflammation at all connected or associated with gut health in the way that you presented?
Yeah, to some degree, but the data on that is so tricky that we don't really know. It looks like there's some minor inflammation for all these disorders, but they're not clearly inflammatory disorders by themselves. None of the diagnostic tests really show that. However, when you look at the kind of trend towards those tests, they all seem to trend towards inflammation. And so we wonder if we're missing something or whether that would work. There is pretty good evidence that HRV biofeedback does have an anti-inflammatory component to it, Kevin Tracy's work. So we are seeing in some areas where people who practice regularly can develop a better anti-inflammatory response without taking anti-inflammatories. And that's an area for the future that looks like it's very promising. We just don't have much data on that yet. Oh, there's one more. I know through my work as well as through my son's treatment for PANS encephalitis that there are emerging studies about gut healing and improved disruption in those patients. Yeah, we think there is definitely there's a lot of interest in the afferent pathways between the gut and everywhere else in the brain. So there is a lot of interest in that. It's just a really difficult area to study. But yeah, I think we're going to see more of that in the future. Thanks for the comment, Rebecca.
Okay, well, thank you so much again, Dr. Gilbertson. We'll
see you guys. Good luck.
Bye.